again, the first step in evaluation is cardiogram. So, what are the current recommendations to get a cardiogram done in a patient undergoing a non-cardiac surgery? Basically, if the patient is a known case of coronary heart disease or any past history of significant arrhythmia, known case of peripheral vascular disease, any cardiovascular risk is present, history is present, or there are any signs and symptoms suggesting of any cardiovascular disease, then getting an ECG is a moderate recommendation.
It has become routine.
Yeah,
no recommendation.
Yeah,
it has become routine.
ECG routine.
Anesthetists will not
go ahead.
Go ahead without.
But like the main crux of this recommendation is that asymptomatic patients who are undergoing low risk surgical procedures, a 12-lead ECG might not be compulsory. That is what the main crux lies. Yeah. Yeah. And those who are having shows ECG abnormalities during the operative evaluation, during further evaluation, that's again moderate recommendation. Asymptomatic patient undergoing high risk surgeries with they are again also recommended to get an ECG done. Now after ECG, the next thing comes is echo. Again, for recommendation for echo, the class 1 recommendation for echo is patient who are undergoing non-cardiac surgery, having either symptoms suggestive of heart failure, or they are showing physical signs suggestive of heart failure, or they are already a known case of heart failure and showing worsening of symptoms. They are like they should have their echo.
तो रिजाइन कर दे यार। बहुत हमने से तो रिजाइन कर।
साहब लोग ना बोलो। ये तो नवी अपडेट थी ना એટલે 5-10 સેકન્ડ વધારે છે.
Again, the crux of this slide is still remaining in the point that the asymptomatic patients who are clinically stable, who are undergoing a non-cardiac surgery, that to a low risk, echo might not be a necessary thing.
See, here the caveat is the patient of severe knee osteoarthritis, not walking much. He does not have any, effort. Because he is not walking, he does not have any complaint. He is relatively asymptomatic.
Okay.
So, even when it comes to echo variation, I will go for not simple echo, I will go for dobutamine space echo.
That is again mentioned down. Echo and ECG usually we do get this days.
પણ
એમાં એવું છે સાહેબ જે લોકો ઓસ્ટિયોઆર્થ્રાઇટિસ નું રિપ્લેસમેન્ટ કરવા જઈ રહ્યા they are invariably into 50s or 60s or 70s so they are otherwise high risk patient તો એનો તો ઇકો કરવો જ પડે એમાં એને સિમ્પટમ નથી કે એ ચાલતા નથી એટલે શ્વાસ નથી ચડતો એ આપણે પેલું ના કહે those who are 65 years of age in need of surgery we have to go get an at least baseline echo done પછી ડોબ્યુટામિન કરવો ના કરવો તે બાકીના એડિશનલ રિસ્ક ફેક્ટર પ્રમાણે સાહેબ કહેશે હમણાં આપણને
ECG and echo, anyways, we are getting done these days very frequently. They are not very non-affordable things, or they are not very.
When it comes to guideline, हमारा guideline में ECG आपको નથી unless the patient is having cardiovascular risk.
પણ તો આમાં એવું થાય સાહેબ કે 60+ વાળું પેશન્ટ છે ને જે ચાલતો નથી એટલે શ્વાસ નથી ચડતો એને તમે એસિમ્પ્ટોમેટિક ના કહી શકો સિમ્પટમ્સ કેન નોટ બી ચેક એવું કહી શકો
રિલેટિવલી મેં શબ્દ વાપર્યો રિલેટિવલી એસિમ્પ્ટોમેટિક
ના ના આમાં ક્લિયર લખ્યું નીચે ઇન એસિમ્પ્ટોમેટિક પેશન્ટ જો થર્ડ નંબર છે ને રિલેટિવ શબ્દ નથી રાખ્યો રિલેટિવ આમાં ના કરી શકાય એબ્સોલ્યુટ જ કરવું પડે
So મારું ચાલુ થઈ ગયું PPT just 1 minute when we were PPT on it.
ગુડ ચાલો તમારું એસેન્સ બતાવો
ટોપિક્સ ને એટલે બધું વેલ ઇન એડવાન્સ ડિસાઈડ નથી હોતું એટલે
એડવાન્સ ડિસાઇડેડ
કે પછી છેલ્લી ઘડીએ જ આમ આવે છે પહેલેથી ખબર હોય છે
नहीं टॉपिक तो लास्ट वीक के डिसाइडेड तो पीपीटी भी बनी गई तो बट सम हाउ आई डिडंट टेक द ऑनलाइन बैकअप दिस टाइम.
સુગર ઓછી નાખવાની તો બે સુગર બહુ છે હા
ओके सर.
હા
तो बोलता हूँ
હા બોલો
सीएसआई की गाइडलाइन नवी आई ना डिसलिपिडेमिया में, ये कोई रीजन का?
हाँ वो नया है
CS
सर, दो
नया है ना अभी, एक आध हफ्ते के अंदर ही आया है.
It is the first guideline released by CSI India that
और अगर हो सके तो आप
yes
કઈ ગાઈડલાઈન છે
कार्डियोलॉजिकल सोसाइटी ऑफ इंडिया प्लीज लिखिए.
ज्यादा फर्क नहीं सर, दो तीन ऐसे लाइंस
वो तो हाईलाइट कर देना.
हाँ ज्यादा फर्क नहीं.
इंडिया रिलेटेड, अभी वी हैव टू बी इंडिया रिलेटेड.
So just 2 minutes. We have this.
સારો તમે ઇકોમાં શું કહેતા તો બોલો ને આગળ
Sir, I mean, nothing but I was put out there. Just I have the PPT ready. Just give me 1 minute.
या दर्शन कहीं नहीं बताया, अब रवे के मैं बना आवता જ નથી બિલકુલ કે 10 જ વાગ્યા છે.
એવું તમે
રેગ્યુલર જ નથી હવે.
તમે કિરણભાઈ તમે એને એસએમએસ લખો દર્શનભાઈ તમારા દર્શન ક્યારે આપો છો
એવું કરવું પડશે.
સર તમારે પારુલબેન લખો પડશે. દર્શકમેન્ટ મેસેજ આપે.
પારુલે કહેવું પડશે, પારુલ હવે દર્શનના દર્શન ક્યારે થવાના છે?
પણ એક તમે સાહેબને મેસેજ કરો કે સીએસઆઈ ગાઈડલાઈન સાહેબ લઈ લે તો મજા આવશે ડિસ્કશન કરવાની. મજા આવશે. એટલે જોક્સ અપાર્ટ એમ આપણે સિરિયસલી રિક્વેસ્ટ
એ
કરીએ.
તો હવે આ બધા કાર્ડિયોલોજિસ્ટ જ થઈ ગયા છે ને, દે વિલ પાસ ઓન મેસેજ ટુડે ઓનલી.
ના એના કરતાં આપણે બી વધારે સારું. યસ આવી ગયું ને.
Yeah.
તમારી ડ્રાઈવ ફૂલ થવામાં છે. લેપટોપ લઈ લો નવું હોય તો.
Right.
સરસ. ચાલો. Now we are having a 7-8 minutes office.
Okay. No problem. You will skip the non-important slides. So these are the number of surgeries and probably 45 patients. 40% plus of them are having cardiovascular risk factors who are doing non-cardiac surgeries. Again, with the growing
એવું લાગે તો બે પાર્ટમાં કરજો, આપણે કોઈ ઉતાવળ નથી, શાંતિ
બરાબર, બરાબર.
એક ડે ઓન ટાઈમ આપણે નેક્સ્ટ બી કરીશું આનો.
Fine. So the most common surgeries that are associated with cardiovascular basis, orthopedic, general and vascular surgeries are the most common surgeries. What are the high risk surgeries? They are the vascular, thoracic and solid organ transplant surgeries. They are usually associated with MACE. And the usual complications are this is what I have mentioned. The scope of the guideline, it mentions it includes the cardiovascular evaluation and management of adult patient undergoing non-cardiac surgery. The guideline covers management from pre-operative till post-operative care, and parts of the guideline are the risk assessment, functional status, cardiovascular testing, and management strategies. Okay, these are the standard. This is what the guideline includes. It includes pharmacological aspect, it includes managing the device-related aspects, and who is this guideline meant for?
My point is the guideline, blue guideline, highlight
Yes.
whether patient is undergoing general anesthesia, spinal anesthesia,
No.
or regional anesthesia.
No, not the anesthesia. Not the anesthesia.
Whether the risk in that case, there are the three categories where the patient gets anesthesia. So when it comes to regional anesthesia, the risk is least, whether it is a underlying patient is having cardiac problem or not.
They have not classified
એનેસ્થેસિયા ઉપર કોમેન્ટ હોય ને હોય છે.
There are only few points જે આપણે મેન્શન કર્યું છે anesthesia
એ તમે લીધા છે ને આમાં તમારા પ્રેઝન્ટેશનમાં લીધા છે એ પોઈન્ટ્સ?
Yeah.
Okay, then let's go. We'll hear.
These are the standard recommendations that we follow through the guidelines. Again, the definitions of surgery as per the guideline: emergency, urgent, time sensitive, elective, low risk and high risk surgeries. These are again the surgeries classified as the common incidence of MACE, high risk surgeries including suprainguinal vascular surgeries, thoracic transplant organs and neurosurgeries, intermediate risk surgeries and low risk surgeries. Apart from the type of the surgeries,
neurosurgery do include spinal surgery?
Yeah. Anyway, not only the type of the surgeries, the other factor that may also contribute to MACE are the patient comorbidities and the cardiovascular risk. Also the surgical technique which has been used, such as if you go for an endovascular stenting for aortic aneurysm rather than the open repair, then the risk is much less. Again, the time consideration of the surgery regarding to cardiovascular disease is also a risk factor. Perioperative cardiovascular testing. First step is usually what we do is ECG. Once again, as we have discussed, those who are having signs symptoms of heart failure, rather having any history of cardiac disease, whether it's a structural or a rhythmic heart disorder, they should have an ECG. As per the guidelines, for asymptomatic patients who are undergoing low-risk surgical procedures, routine ECG might not be necessary. And these low-risk procedures usually includes dermatological procedures, cataract and some other ophthalmological procedures.
Most of the time local anesthesia.
And dental procedures. Usually a local anesthesia.
Those who are undergoing local anesthesia procedure.
So એનો ક્લાસ ઓફ રેકમેન્ડેશન જે છે રેડમાં એ શું લખ્યું છે? 3.
There is no significant benefit to one.
Yeah, so its class of recommendation 3 છે. લેવલ ઓફ એવિડન્સ શું લખ્યું છે તેનું બચાવ્યું?
B.
B. એટલે એના કોઈ રેન્ડમાઇઝ ટ્રાયલ નથી.
There is a trial I have mentioned without any.
B ની બાજુમાં શું લખ્યું છે?
Not recommended. NR stands for that. But
NR stands for there are no randomized trials.
And basically, I have mentioned it in my coming slides that it's mainly lacks any benefit to the patient. That is why it is not recommended. But usually it's a very easy thing to get this result. We do get, so we are not going much into details. What are the ECG abnormalities that we should have in mind while looking at ECG of a perioperative patient? So these are the changes that evaluates for that necessitates further evaluations. These are tubular changes and signs of hypertrophy. Any significant aesthetic changes, any significant blocks, that is Mobius type 2 or any high degree block, presence of atrial fibrillation or QT prolongations. Again, the age, with increasing age, there is also high chances of getting these abnormalities in the ECG. So this was the study mentioned in the guideline, again without the name, but they had included about 30,000 plus patients undergoing non-cardiac surgeries for ECG evaluation. And out of those 30,000 patients, only 14 patients had any ECG abnormalities that led to some perioperative management change. And out of those 13, one had a onset AFM, other 12 had ischemia. Those 13 underwent non-cardiac surgeries, and only one of them had any cardiac side effects during the perioperative period. So basically, the crux of the presentation lies in low-risk procedures, stable patient, asymptomatic patients without any history of cardiac illness. ECG might not be necessary.
આમાં દાવ ક્યાં થાય ખબર તો? This is just 0.04% cancellation, right? જ્યારે તમે 0.04% પેશન્ટ સાથે ડીલ કરતા હોય ને ત્યારે ઇટ્સ ઓલ ઓર નન. કાં તો એને કોમ્પ્લિકેશન થશે અથવા નહીં થાય.
See, like again, that should be.
See, I agree to the guideline. તમે સાંભળો હું મેસેજ શું આપું છું કે આપણે કેમ છતાંય એનેસ્થેટિસ્ટ હંમેશા માગે છે અથવા પ્રેક્ટિકલી બધા જ પેશન્ટના ECG થાય છે because whether he or she will fall in 0.04% or 99.96%, that we cannot say.
Okay. No, so, again, I am only saying that guideline says so.
Agree.
Getting ECG is not a difficult
એમાં
thing.
observation કીધું તમે. I agree to your guideline.
અને લીગલી પણ તમે આપણા કન્ટ્રીની અંદર તો લીધું હોય તો કોઈ ના નહીં પાડવાનું કે ઇટ ઇઝ નોટ નામ ના લીધું હોય તો વધારે
That is
બેઠું
why I'm not too much emphasizing on that part. Okay, bhai, narrow ECG, that is what I'm saying. This is the guideline says, but again, getting an ECG is
ના લીધો હોય પેશન્ટ ન કરીને નારાયણને મરી ગયું કાર્ડિયાક એરેસ્ટ તો તમે લીધો તો પહેલું એક
then again maybe we can show them the guideline. Okay, very low risk procedure, nothing going to it. So
એમાં કેવું છે કે માનો કે પેશન્ટ એનાફાઇલેક્સિસ થી મર્યો અનફોર્ચ્યુનેટલી કે ક્રિટિકલ થઈ ગયું આઈસીયુ એડમિશન થઈ ગયું અને અનફોર્ચ્યુનેટલી તમને આ લો રિસ્ક સર્જરી હતી તમે ECG નથી લીધો યુ કેન નોટ ઇમેજિન કેટલા લેવલનું ડેમેજ થઈ જાય પછી એ ફિઝિશિયન હતા કાર્ડિયોલોજિસ્ટ હતા કે ઓપરેટિંગ સર્જન હતા કે જે બી હતા. Right? Suppose you don't have a pre-operative ECG and unfortunately patient ends up in an ICU post-procedure, whatever low risk procedure, any damage is irreparable.
like where I am presenting this, my point only lying in representing the guideline. I am not saying you should not take ECG.
Exactly. આ તો અમે અમારા observation
Yeah.
કરીએ છીએ. It's fine.
Yes.
ECG and echo are very feasible, cost effective, not having any side effects. Definitely we get it done in most of the patients. But this is what the guidelines say. That is what is what I am.
ગાઈડલાઇન્સ આ ગાઈડલાઇન્સ
Yeah. Again, we have seen the echoes and the recommendations are just about the same. Those who are having just signs or symptoms of heart failure, those who are in case of heart failure and showing any worsening of that, they should definitely get an echo done. Again, asymptomatic clinically stable patient undergoing low risk non-cardiac surgeries. Echo might not be a mandatory thing. How would the heart failure affect your non-cardiac surgery? It increases the 90-day mortality by about 5.5% in a patient with symptomatic heart failure. Again, 4.5 about 5% in asymptomatic heart failure patients. As compared to the patients who are not having any heart failure, the mortality is much less. Again, IPF less than 30% is the independent risk factor and also again having slightly higher mortality. Yeah. So this was again one study that was mentioned in the guideline and it showed that in a routine non-symptomatic patients without any cardiac history undergoing low risk procedure, the echo evaluation didn't add much to the benefits to the patient. After echo, the next thing we look at is the stress echo or stress imaging. Once again, the recommendation is either moderate or it's a more benefit thing. So for the patient undergoing elevated risk non-cardiac surgery with a poor or unknown functional capacity, what the sir has mentioned, a patient of osteoarthritis who cannot walk, in which we cannot define the functional capacity of the patient based on the history only. For them, stress echo might be a good tool to evaluate the patient. Once again, the patient who are undergoing low risk cardiac procedure, having adequate functional capacity, those who are asymptomatic, routine stress echo might not be a necessary thing.
So at the moment the highest recommendation is 2B.
Yeah, 2B
Class
is the
of
recommendation.
recommendation, right?
And again, because the presentation was getting out, I have not mentioned, but they have mentioned in the guideline. When we do it, it is not to detect the probability of a coronary artery disease. આપણે stress echo hidden ischemia ને identify કરવા માટે નથી કરતા. It is just that if it is showing any reversible myocardium or any signs of ischemia, it might add to a certain degree of risk factors. Otherwise, not per se to identify any hidden ischemic disease.
But it is not a reference of only dobutamine stress echo. It is also for exercise stress.
Exercise, dobutamine stress echo, as well as the
આમાં જે નીચેનું સ્ટેટમેન્ટ છે કે poor functional capacity is considered less than 4 meds and what is considered as an adequate capacity more than 7?
now more than 4 minutes.
Right?
They have mentioned it.
Okay. એટલે 4 meds તો જનરલી 1.5 મિનિટમાં જ 4 meds તો થઈ જતા હોય કદાચ એની વેલા થઈ જાય.
There are two things. One is a scoring pattern, which again I can show you before coming slides. And second thing is more than 4 minutes. They are considered as necessary functional capacity of the patient for
More than 4 meds, right?
Yeah.
Okay. એક મિનિટ હજી નીચે શું લખ્યું છે બીજું?
नहीं, this is CCTA.
ઓકે પણ હા ઓકે ડન પણ નીચેનું વાક્ય મને અહીંથી વચાતું નથી વાંચો જરા નેક્સ્ટ હતું ને
नहीं, that is for CC.
ઓકે એ તમારે ડિસ્ક્રાઇબ કરવાનું બાકી છે કરી
Fine. So, CCTA recommendation for which are either to be or no benefit, again similar to that of stress echo. And what would be the patient for which we will go for a CCTA? Those who are having elevated risk surgery, poor functional capacity again. Those, so basically a high risk patient undergoing moderate or high risk surgery. CCTA, getting a CCTA done will add on to risk factors. It has more of a negative predictability rather than a positive predictability that I have mentioned in my studies.
હવે જે નીચે જે એસ્ટેરિક લખ્યું છે ને એમાં more than 50% of left main stenosis or
Yes, sir, I have mentioned it in coming slides. कि CCTA નો role क्या આવે છે that I have mentioned. So these are the patients who should get a CCTA done. Those who are in poor functional or intermediate functional capacity, and those who are having a high risk suspected coronary anatomies. Why?
आज તમારા load less than 4 medicine, most of the obesity patient die.
But એટલે સર આની આગળની સ્લાઇડ્સમાં છે કે એનો બેનિફિટ શું છે and why you should get it done and why.
For a 120 kg person not walking much.
Okay.
120 kg obese person છે અને એનો BMI almost 40 છે. What is the criteria? Just because the number of obese people are increasing, undergoing surgery is increasing.
So that is what the guideline says. Any matter compulsory નથી. You may get it done. You may get it done to evaluate the cardiac risk further. And with the traditional risk scores, if we add on CCTA findings, and if the CCTA findings are suggestive of some abnormality, then it adds to the risk. If the CCTA findings are normal, then again it benefits to the patient.
તમારા પ્રશ્નનો જવાબ એવી રીતે થાય સાહેબ કે જો less than 4 માં જે થાકી ગયો ચાલતા that it patient it's his herself or himself will understand કે જો આપણું રિસ્ક વધારે છે A B પણ ઘણા લોકો તોય પૂછ કરશે શું થશે તો CT coronary angio એડવાઇસ કરી દેવા
કરી શકાય.
yeah it's may be considered કે તમારા જે ફાઇનલ આન્સર
આ બધા જે ફેક્ટર્સ છે ને these factors are કે જેને holistic approach કહેવાય. Holistic approach means you individually assess the patient કે એને risk factor શું એપ્લાય થઈ શકે.
Yeah. So the point I am trying to make is કે ભાઈ બધા પેશન્ટ માટે જરૂરી નથી. So called high risk patient and so called this defined patients, any other you may get it done. And what are the benefits that we can see?
એમાં એવું બને કે less than 4 minutes ખાલી ને ખાલી એની ફિઝિકલ ઇનએક્ટિવિટી ને લીધે કે વેઇટ ને લીધે બી થયું હોય અને એક્ચ્યુઅલ કાર્ડિયાક ને લીધે બી થયું હોય તો એ તમારે ડિફરન્શિએટ કરવું હોય તો ઇઝ ઓલવેઝ બેટર કે તમે CT એન્જિયો કરી લો ઇટ્સ ફાઇન.
Yeah. And basically the test has a good negative predictability. When normal આવે then it shows a low probability of getting males during perioperative periods. And again, if we get any positive findings, then if your CCTA is suggestive of any single vessel heart disease, then there is an increased risk of males by 3-fold and multivessel disease increased risk of males by 8-fold. Again, why you should not get it done routinely? Because it unnecessarily increases the risk. So it unnecessarily increases the risk predictions. So likelihood of males and unnecessarily leads to delays of surgeries. So for a routine walking patient, it's not necessary. For high risk patient, you may get it. That's what the slide want to say. After CCTA, what we go have the guidelines for angiography, and this is what the guideline has mentioned. Just one statement. A routine invasive coronary angiography is not mandatory to get a patient undergoing non-cardiac surgery during the evaluation. And why is it so? Because even if we are we do angiography and we do find any ischemic heart disease or any coronary obstructive artery disease with a stable in a patient with a chronic coronary disease, the routine revascularization is usually not helping any patients by any much means. This is what the guideline is to get. After this routine test, there is calculators. Again, you might not be able to see all the factors. So these are the scores available, and all the scores include different parameters. Their outcomes are different. The commonly used is a CRI1. The online calculators for which are available, and you just select
Revised cardiac risk
index.
revised cardiac risk index.
And it clearly shows the percentage of probable MACE in that patient. The limitations of such scores are that they all use different criteria, their outcomes are different, and there is no proven studies that shows that one particular criteria is more accurate or rather more beneficial to the patient. What the study is trying to suggest, if you combine two or more criteria, then the risk prediction is slightly better. Once again, the biomarkers, the recommendations for the biomarkers are there in the new guidelines. For pro-BNP, it's a moderate recommendation that patients who are having a known CVD, those who are either age more than 65 years or those who are more than 45 years with the signs and symptoms of CVD, particularly heart failure, it is reasonable to get a pro-BNP done during the Peri operative evaluation. It has got some prognostic value that we'll see in the coming slides. For troponin is again those who are having no CVD, those who are, the similar kind of recommendations are there for the troponin. So what are the benefits of getting this anti-pro-BNP thing done? So elevated levels are again associated with the high incidence of MACE during the 30 to 180 days in the perioperative period. The limitations of doing pro-BNP. With regard to the prediction of MACE, there are no clear-cut levels defined at present, above which we can identify the MACE, likelihood of MACE is higher or not.
What I go to the is that the high risk patient I got get anti-pro-BNP done. It little bit high. What I suggest, give fluid, restricted fluid. The amount of fluid they infuse, anesthetic. I usually ask them to restrict the fluid and get the anti-pro-BNP done next 48 hours. Every day for next 48 hours. That is what I do not go by guideline, but this is what I follow.
Okay.
Because by restricting the fluid, you are at least avoiding, even if heart failure occurs, it is mild.
Just, this is the table available. We can just go through the table in this PDF. It shows the, as far as the evolution is concerned, this is the flow chart that the guideline is suggesting. Whatever might be the cardiovascular risk factors, signs and symptoms, etc. If the surgery is emergency, you go ahead and do the surgery. If the surgery is not an emergency one, so it is not an immediate threat to life or limb, then you can look at the three factors. If there is an presence of ACS, if there is a presence of any arrhythmia with hemodynamic instability, or if there is presence of decompensated heart failure. If that is there and the surgery is not an emergency one, then you can again first manage the cardiac aspect and then think about the surgical part. If it is not about these three conditions and it's not an emergency surgery, then again you look at this sixth aspect, whether it's a severe valvular heart disease or severe PH, any high complex congenital heart diseases, any recent history of stroke, if the patient is having any cardiac device, then the surgical guidelines are as follows. You go ahead with the cardiac risk factor scores, and if the scores are lower side, then you go ahead and do the surgery. If the risk factors, the clinical scores are higher on the higher side, then you get an ECG and further evaluation of the patient's done. And surgery is after getting the cardiac testing done. If the risks are again low, then you go ahead and do the surgery. If the risks are falling in the intermediate category, then particularly guideline mentions getting a troponin done. If they are normal, go ahead and do the surgery. If they are abnormal, then again the decision for surgery has to be multidisciplinary. It has to be decision made combined by the cardiologist as well as primary physician and surgeon together. So this is the now lies the management part. The most common thing
Give me the right place,
so ઓછી છે અને we can go through it very quickly in 10 minutes.
Around 9:31 છે.
Third part 3 Act 2.
Okay. Otherwise 10 minutes will be finished.
અને બહુ day
ના 10 મિનિટ્સમાં ફિનિશ અમે નહીં કરવા દઈએ બરાબર પેલું તમારું